Hi guys, welcome back. We shall now be talking about advanced cardiac life support and I'll be explaining to you what is the difference between this and basic life support. That's the usual query that I get from most doctors because we're doing a lot of things that are same. We are still doing CPR, we are still taking care of the airway of the patient, breathing, circulation. So isn't everything same? Yeah, it is. But there's a difference. The fundamental difference is that you are here making a differential diagnosis in a patient, that is ABCD. The D stands for differential diagnosis, that is being done by the doctor here to identify why did the patient become pulseless and BPless. It could be ventricular tachycardia, broad complex QRS, where the heart is beating very fast, so it's not getting time to get filled with blood, so if input and output both are falling. It could be asystole, for which the treatment is totally different from that of ventricular tachycardia, or a patient could be having a tension pneumothorax, which is compressing on the SVC, IVC of the patient, reducing the venous return, so the heart is literally beating empty. You can understand an empty heart will not be able to generate any pulse. Pulseless electrical activity could be due to conditions ranging from dangerous hypovolemia, where there is fluid loss from the body or fluid shifts in the body, or it could be tension pneumothorax, which is compressing the superior or the inferior vena cava, compromising the venous return of the patient. So in advanced cardiac life support, you make a differential diagnosis and then treat the patient accordingly. In basic life support, your objective is just to maintain brain perfusion by giving chest compressions to the patient, but here you are trying to do something beyond routine chest compressions also, that is to identify the cause and treat it. Aiding you in the very first step here is a defibrillator. When I say that the usual query from most doctors is that were you not using a AED or automated external defibrillator even in basic life support, so what's the difference? The difference is that this is automated external defibrillator. When you put it on the chest of the patient, it decides whether the shock is to be given or not given. So the AED will give out command. It will come out with a talking software in it, will say the word shockable rhythm detected. So the decision making was done by the machine. Whereas in case of ACLS, the defibrillator will tell you a rhythm and the decision making will be done by the doctor. So I highlight this. In basic life support, you are giving CPR to the patient, like the person collapsed at the airport. One of the persons went to get the AED machine. You are the one who is giving CPR. The moment the AED machine will come, you have to deploy the paddles on the chest. Now it will read the rhythm and say shockable rhythm detected or not detected. If not detected, you continue with CPR. On the other hand, if it says shockable rhythm detected, stay clear, then you have to wait for a few seconds and the machine will deliver a DC shock to the patient. Please appreciate automated external defibrillator decision making is that of the machine, whereas in case of ACLS, the decision making is done by the doctor. So that's one of the fundamental differences here. Like for example, I can say asystole is a non-shockable rhythm. Ventricular tachycardia is a shockable rhythm. So the decision making was done by the physician. Another highlight that I can say, especially for the airway, is secured. You would go in for advanced airway here, like you will intubate the patient or you can use a laryngeal mask airway. In most of the cases in our hospitals, we intubate the patient. Now, once the advanced airway has been secured in the patient, then you will not follow the 30:2 rule that was taught to you initially. Now you will be giving one breath every 6 seconds. I repeat my statement, the 30:2 is not to be followed anymore. Like one guy is giving 30 chest compressions, fine. But if you are the one on the ambu bag, you have to press the ambu bag once every 6 seconds. So one breath every 6 seconds will translate into total of about 10 breaths in 1 minute. Another difference that I want to highlight before you is the difference between the term defibrillation versus cardioversion. A common query from a lot of my students is that after all, sometimes you say defibrillation, sometimes you say cardioversion. After all, you are still giving DC shock to the patient. So what is the difference? The difference is that when it comes to the term cardioversion, you are delivering the impulse with respect to the peak of the R wave. So cardioversion means synchronized DC shock. In fact, this is itself a question asked both in anesthesia, emergency medicine, so we can handle it here. I have covered this question even in the cardiology component, but anyway, because the concept came up, so I have to talk about again. That synchronized DC shock means that the impulse is fired at the peak of the R wave. Why do we do it at the peak of the R wave? Mainly because that is the time when the heart is contracting abnormally. So when I will give this shock, it will make the heart electrically silent for a while. It will relax. It will get filled with blood properly. And now when it will contract the normal sinus rhythm, the SA node will take over the activity. So next time when it will contract, the contractions will be normal and there would be a normal cardiac output that will ensure brain circulation or return of spontaneous circulation, as we say. So cardioversion simply means that it is a synchronized DC shock with the peak of the R wave. Like for example, in this display or the image, you can see the hands of the doctor giving CPR and the paddles have been put on the chest by his colleague. Now you can notice a doctor pressing on a button which will deliver a synchronized DC shock. You can adjust the power, you can increase the power of DC shock, you can decrease the intensity of DC shock by this display button here. Then once you've set the particular value, you will press on this button and say shocking. When you say shocking, obviously everybody will stay clear of the patient, and now this computer will deliver, and you can see on the display also it will be written synchronized biphasic 120 joules delivered to the patient. Like on the right hand side image, I have shown a PSVT run in a patient, and now a synchronized DC shock has been fired with respect to the peak of the R wave of the patient. However, when it comes to the image on the left hand side, a doctor has not synchronized it to the ECG. Like in this case, a person is having a clear-cut ventricular fibrillation. So in ventricular fibrillation, because there is no ordered activity, no PQRST wave, so we will just go in with random firing, which is the impulse will be fired irrespective of whether it is PQRST wave in the ECG. So the left hand side here shows what we call as defibrillation. I highlight the terms here. One is defibrillation, which is irrespective of the phase of the cardiac cycle. And second is cardioversion, which is done with respect to the peak of the R wave. Cardioversion is what we do for arrhythmias like paroxysmal supraventricular tachycardia or patients of atrial fibrillation if they require it, atrial flutter if they require it. On the other hand, defibrillation would be done for following situations. That would be ventricular fibrillation as shown on the display and a patient of pulseless ventricular tachycardia. Here there is no synchronization with the ECG. It's random irrespective of the phase of the ECG that has been delivered. So a PVT here means pulseless ventricular tachycardia. Like he could be having a monomorphic broad complex QRS. The patient is pulseless. Why? Because only the ventricles are contracting. First atria should contract, then ventricles should contract. If you're gonna be having only fast ventricular contraction, they will not get filled with blood the ventricle. So input and output both will be hampered in a person. So once you get these differences right, we will now be in a better position to discuss regarding the rhythms that we're gonna treat in the patient. On the right hand side of the display, you can notice a flatline ECG that is asystole. But then I'm describing a patient where you can see normal sinus rhythm. You can decipher P, Q, R, S, T waves. There is a normal sinus rhythm, but the patient is still pulseless. So we call it pulseless electrical activity. The causes of this can be manifold, like the heart could be beating empty. Example can be a patient of mine did not like my treatment. He brought a gun with him. He shot me in the aorta. You can imagine if I am shot in the aorta, if I'm losing blood from my aorta, my heart is still beating. But it is an empty heart because if the aorta is punctured, well, the end of the game, Indian patients are nasty nowadays. They can fire at you. So whatever, you have to be mentally prepared for that. But what I'm saying is that if my aorta is punctured, if my aorta is having a big hole, it's leaking blood, or aortic dissection, you can take another example. If I'm hypertensive, I don't take care of my health, no medications for hypertension, aortic dissection, again, the heart is beating empty because the blood is flowing in that false lumen that is created. So hypovolemia, tension, pneumothorax, cardiac tamponade are few conditions where the electrical activity of the heart is very much there, but there is no pulse. Why? Because the hemodynamics are compromised. In cardiac tamponade, the heart is crushed so badly that input will be less and output will also be less. On the left hand side, however, you can notice a very asymmetric twitching of the heart, that is ventricular fibrillation. And then you can see this broad complex QRS which is present, which is a monomorphic ventricular tachycardia. Why we have studied about them? Well, these are 4 rhythms which decide the algorithm of advanced cardiac life support. For the left hand side, you will deliver a DC shock to terminate the arrhythmia. You will defibrillate the patient, so we will call them shockable rhythm. But on the right hand side, there is no role of giving a DC shock. In Grey's Anatomy or television serials, they show like this: flatline ECG, doctor is giving DC shock, patient is recovering. I have highlighted time and again, DC shock is not, or cardioversion or defibrillation overall, is not to restart the heart. It is to terminate the abnormal electrical activity. In asystole patient, I will give repeated shots of adrenaline. Adrenaline will be the one that can trigger development of ventricular fibrillation in a patient. So why do we give adrenaline in patients of asystole again and again and again? Is because you give it 1 milligram every 3 to 5 minutes. Why? Because when you give adrenaline again and again and again in flatline ECG asystole, you convert it into ventricular fibrillation, and the moment you convert it into ventricular fibrillation, then it becomes a shockable rhythm. So I also wanted to highlight from here that these are not rigid lines. A person from shockable rhythm can go into non-shockable, from non-shockable can come to shockable rhythm. The bottom line is, why do you give adrenaline in asystole? It acts on the SC node, but it's not able to mostly attain a normal sinus rhythm. It triggers a disordered activity. The moment you get a disordered activity of ventricular fibrillation, you hammer it with a defibrillator using a DC shock, that is a non-synchronized DC, and the rhythm can then stabilize to normal. But please remember, as long as flatline is there, hold your fire. Because flatline is there, I said hold your fire. So this would be called as non-shockable rhythm. So you are the team leader. You will decide whether the firing of the defibrillator is to be done or not done. The decision making is done by the team leader, who has to give orders, and the remaining people are obviously the team members who have to follow the command. So the team leader, so the chain of command has to be very clear when it comes to advanced cardiac life support. And if you get these 4 rhythms right, well, you are bang on target to identify and then manage the patient accordingly. At the bottom of this table, I have also shown a ECG that you might have seen in patients who are just close to death. Well, this would be called as agonal rhythm. What I mean by agonal rhythm is that this might be few last breaths of the person. These are not normal breaths. These are few last ditch efforts of the brainstem of the person to send some oxygen in the body. And you can notice there is no SN node firing. All you are having is a very irregular broad QRS complex that is coming, because maybe that is due to the firing of the bundle of phase, which fires at only 15 to 20 beats per minute. So there's only like 15 to 20 beats of contraction occurring, and before it becomes a flatline. Like after this, it could become a flatline ECG in the patient. It could become a asystole in a person. So I have shown 3 different strips to you where you might be having these irregular broad QRS complexes which are present, no normal cardiac synchronization or normal cardiac activity noticed, and the term used for this is agonal rhythm. And agonal rhythm can occur before and after any one of these. It could be with respect to asystole, before asystole, it could be post asystole in a patient. So all of these rhythms are artificially created by us in this tabular format, because we want to make a differential diagnosis of a patient. Like left side, I will give a DC shock, right side, I will not give a DC shock to the patient. Here, I would also like to mention regarding what do you mean by the word treatment of reversible causes. I'll explain here the 5H and the 5Ts to you, though I have covered that in the pulseless electrical activity algorithm also, but let's practice this here. One of the H would be hypovolemia. Let me put it like, if I'm a big time smoker and I'm having a abdominal aorta aneurysm. Now, if it just pops up, like it is more than 5.5 centimeter, it can rupture anytime. So all my blood is lost into my peritoneal cavity and my heart is beating empty. So you need to go for aggressive resuscitation, a massive transfusion protocol. Next is hypoxia, which is understandable. I mean, the fuel for the heart is oxygen. If oxygen is not there, the performance of the heart will be compromised. Then we have a basic set, like we have a ideal range of PCO2, we have a range of pH. So protons cause damage to myocardium. Protons can cause damage to the blood-brain barrier. They can cause an encephalopathy. So metabolic acidosis can be treated by soda bicarbonate. Potassium can affect repolarization of the heart. If potassium is too low, there could be arrhythmia by the name of Torsades de Pointes. I'll repeat that and rather reiterate that statement. Hypokalemia kills a man due to diaphragmatic paralysis. But the arrhythmia with hypokalemia is Torsades de Pointes, and with hyperkalemia, most of the time we get a bradycardia in the patient and then a development of flatline ECG, that is asystole. So both have to be kept in mind, because Torsades de Pointes, if present, you can give a DC shock, but if it is hyperkalemia, then you will have to, for asystole, go for the algorithm which would be involving usage of even adrenaline apart from specific treatment for hyperkalemia. Hypothermia, well, the heart beats relatively slower, so hypothermia is always to be kept watch out for. At least 2 H's can be evaluated by simple physical examination when you resuscitate the patient. If you are having pulses which are very feeble, or if you are having person who's icy cold to touch, like a soldier brought into the casualty, 2 H's can be identified easily. Alphabet T. The 5 T's would be identified like, one is tamponade. I'm not handling toxins first because we'll go by exclusion. Tamponade is pressing on the heart from outside, so input and output both is lesser, and cardiac tamponade can be picked up by electrical alternance in the ECG. Tension pneumothorax can be picked up because there would be unequal breath sounds on two sides. There is absent breath sounds on whichever side pneumothorax is present. Then other two thrombosis. One could be coronary artery disease, like the person is having left anterior descending artery getting blocked, that is anterior MI, or worst even main left coronary artery getting blocked, that is extensive anterior MI. So person's cardiac function will decrease. Or it could be a patient of massive pulmonary embolism. So T thrombosis is for two. One is the thrombus in the coronary artery, other could be thrombus in the pulmonary artery. Massive pulmonary embolism will cause obstruction of blood from the right ventricle into pulmonary artery. If right ventricle can't send blood forwards, then the blood of the left is dependent on the right. The BP will crash. So acute cor pulmonale is what he's talking about here, and can be picked up by findings of right ventricular failure to small sign developing in a patient. And if none of these are present, if you're not having electrical alterance, you're not having unequal breath sounds, you're not having ECG findings of ST elevation, massive pulmonary embolism, you're not having findings of small sign and right ventricular strain, then it could be toxins. So your brain has to work out logically. I'll say that again. One could be electrical alterance in a ECG identified. Second could be unequal breath sounds as an indicator. ST elevation for CAD. Then could be massive pulmonary embolism. That could be findings like S1, Q3, T3, and findings of right ventricular failure, acute right ventricular failure manifestations developing in a patient. So if these are not present, then it is toxins to be considered. It could be like TCAs overdosage, digoxin overdosage, that can contribute to these manifestations. But treating the reversible causes will come subsequently. First would be obviously to ensure that he lives. Let us now look at the actual algorithm that we discussed or studied in advanced cardiac life support. And it's very straightforward because there are 3 boxes on the left and 2 on the right, and you can fill up the data by yourself and you would be able to understand this relatively better. I have initiated CPR in a patient, given him oxygen and attached defibrillator. This person had collapsed at the airport suddenly, now is in the premises of my medical room, so I have attached defibrillator on the chest of this person. The defibrillator will tell me whether it is a pulseless ventricular tachycardia / ventricular fibrillation, because I know that these are shockable rhythms. On the other hand, if it is a flatline ECG or a pulseless electrical activity, then my mind is racing to the possible causes of a pulseless electrical activity. Let us handle the left side first. The moment I notice a pulseless VT or ventricular fibrillation, I will deliver a DC shock. The red wavy line represents a DC shock because that is the treatment of choice for these patients. That is, defibrillation has been done. This is a non-synchronized DC shock which has been done. It's not going to correlate with any wave of the ECG. The moment you give DC shock, the impression or the thought process of everybody is to look at the monitor, because we want to see whether the rhythm is coming back to normal or not. You see, you as the team leader will obviously look at the monitor to judge the response of the DC shock that you have delivered, but the person who's giving chest compression is supposed now to give CPR for another 2 minutes. Why that is so is because of the fact that the heart has just recovered. Like, let me say the rhythm is coming back to normal. You give a DC shock, it is converted to normal sinus rhythm, but the initial few seconds to minutes, heart may not be able to generate sufficient cardiac output to supply the brainstem. Please appreciate, in the brainstem we have vital centers like the pre-Butzinger complex, respiratory center, vasomotor center. So I want to ensure blood supply to the important vital centers in the body. So I will instruct my team member not to look at the monitor and check for response. Rather, he is supposed to give another 2 minutes of high quality chest compression to the person to ensure blood supply to vital organs, especially the brain. Another team member will be instructed here to obtain an intravenous or an intraosseous access, which should be taken as close to the heart as possible. I am assuming the worst case scenario that this DC shock has failed. What I'm gonna do next? Give a DC shock for the second time. So continue counting the number of DC shocks that I'm gonna use. I have given a DC shock once, no improvement. It's gonna we are gonna defibrillate the patient again, and I'm gonna ask my team member the moment the DC shock is delivered to give another 2 minutes of CPR so that we can give support to the vital centers in the brain. And because the IV access in this particular case has been obtained / intraosseous, so I will use this opportunity to deliver epinephrine to the patient. The dose of epinephrine will be 1 milligram. It will be, however, 1:10,000 dilution. How do you make it? You break the ampule. In the ampule is 1:1000 dilution. You mix that with 9 ml normal saline, so it will become diluted to 1:10,000, and that entire 10 ml is to be pushed. That 10 ml, I repeat that again, 1 ml was adrenaline, 9 ml was normal saline. So total in the syringes, you can take a 20 ml or a 10 ml syringe, whatever is comfortable for you. So 10 ml entire has to be pushed. Why? Because when a person is having abnormal rhythm activity in the heart, the circulation is impaired. So the possibility of the drug not reaching the heart is definitely very much there. So we will give support to the SA node by giving epinephrine to the patient. And now we will also intubate the patient. That is called as achieve advanced airway. It is important at this point of time to correct the hypoxia component, which will anyway come in the body. So advanced airway will ensure that a definitive ventilation of the lungs is done properly. You can also use capnography along with that, because this will one tell you that the tube is in the esophagus or in the lungs, and once the EtCO2 is measured or is evaluated, then it gives you a reliable index of the fact that you are ventilating the lungs properly. I am assuming the fact that I have intubated the patient, but still the rhythm has failed to revert back to normal. So I'm gonna do a third DC shock delivery to this person. Please appreciate the fact that after I have achieved a advanced airway in the patient, I'm putting a star mark here, I'm putting a star mark here for advanced airway. Once advanced airway has been secured in the patient, now the breathing of the person will not be the same 30:2. Before the intubation of the person was done, it was 30 chest compressions, 2 rescue breaths. Now the breathing will be, because you are gonna attach the endotracheal tube to the ambu bag, so you will be giving one breath to the patient every 6 seconds. That will mean the total of 10 breaths per minute will be delivered to the patient. I repeat my statement once again. On advanced airway securement, you are not supposed to continue with 30:2 ratio. Now chest compressions will remain same, 30, but the breathing frequency of the patient will now be one breath every 60 seconds. So chest compressions are anyway gonna be given because it is failed to revert back to normal. So I'm gonna write the word CPR again for 2 minutes. You can see that almost 6 minutes are going by. Brain dies usually within 4 minutes. So we are mostly gonna lose the patient. However, one last ditch effort that I will do here, and that is a must know for you for all those mega code questions that you come or encounter. The word is mega code questions because whenever they use the word ACLS, they use the word mega code. So the drug that you will use here for a person who has not responded to the routine 3 DC shocks is amiodarone. The first dose is given at 300 milligrams. The second dose can be given at a gap of 3 to 5 minutes at 150 milligram. But amiodarone is useful for ventricular tachycardia anyway, and it is also useful if it is a shock refractory ventricular tachycardia in the patient. Along with this, another thing to be looked up for is treat reversible causes. I have already mentioned what I mean by reversible causes is like hypoxia, acidosis, toxins. They have to be also considered in the patient because they could have been responsible for triggering of these arrhythmias. However, let us assume that the person was having a non-shockable rhythm, pulseless electrical activity or asystole in a patient. I'm going to put a blue line here to say there is no point of shocking this person. We will anyway provide CPR to the patient for 2 minutes, and the main treatment on this side would be intravenous / intraosseous, whichever possible. In case of intraosseous, we can deliver it into the tibia, or in case of trauma cases, we can even deliver it into the sternum of the patient. Though, I mean, it would look very horrible to inject it into the sternum, but they say that epinephrine can be given both intravenously and intraosseously in the patient. Along with this, the next step to be done is intubate the patient. So advanced airway with capnography. You can notice that advanced airway came in the second box on the left hand side, but advanced airway is written in the first box itself on the right hand side for non-shockable rhythms. Capnography will give you an accurate estimation of the fact that whether you are ventilating the patient properly or not. Once you have done this activity, you need to go for the next step, that is again give CPR for 2 minutes. Repeat the shot of epinephrine to the patient. Epinephrine can be repeated every 3 to 5 minutes. One of the reasons why you give epinephrine in asystole is to convert it into ventricular fibrillation, as I've explained in the earlier slide. So you might have to give a much more number of shots, and along with that you have to simultaneously evaluate the patient for reversible causes. Most of the time, the thought process of yours for reversible causes should be mainly focusing on the hypovolemia component, as I explained to you. In case the heart is empty, you need to give fluid resuscitation. If it is hypothermia, you need to go on for active rewarming of the patient. So in the HAs, the first two things to be always considered are hypovolemia and the hypothermia component in the patient. And if they're taken care of, you can definitely improve the patient. Do remember the fact that patients on the left hand side can get converted into right hand side, in a sense that asystole patient can get converted into ventricular fibrillation. So then the algorithm for ventricular fibrillation can also come into picture. So we can be having a dynamic state where the person can be moving from left to right and right to left. And if you are going to aggressively treat these patients, then the chances of survival of these patients will be substantially improved. Assuming the fact that you have been able to successfully implement what I've said in the form of development of ROSC. ROSC stands for return of spontaneous circulation in the patient. You would next, as a last step, go in for TTM, that is a targeted temperature management. The objective is to ensure therapeutic hypothermia for the patient. I have explained this even in management of raised ICT that therapeutic hypothermia is neuroprotective. I'm adding to that the statement of mine is therapeutic hypothermia is both cardioprotective and neuroprotective. Whatever damage has occurred in this person has already occurred, but what you can do is limit the further progression of the damage by ensuring this therapeutic hypothermia. The prognosis of these patients is obviously bad. I would not say that these patients would walk and talk again, especially if the cerebral hypoxia component has been substantially long, and that can cause intense emotional trauma for the relatives. In fact, they might ask you that why did you save this person to lead a suffering life like this? But then please appreciate the fact that we as doctors, we try our best to save our patients, even if it is out of 100 cases 99 lives are lost. One, even if you are able to save, it is definitely gratifying to see the smile on the face of the patients. And I'm very sure on your Facebook profiles, your friends, etc., at sometimes would have posted that you got a case in the casualty or he or she got a case in the casualty which was like, non-salvageable, but simply by applying this protocol they were able to save the person. So this has been documented very well. This is the routine protocol of American Heart Association that I've discussed with you. The next protocol is scheduled to come on October 2020. So that is what is mentioned on their website. So before your exam, I might have to update this video once again, because if they make some radical guidelines and they would like to ask that in January 2021, then I would like to obviously you to be aware of that. But till that video, I want you to listen to this carefully, because every time in the update there are a few minor aberrations here and there only. Like for example, in 2015, the radical change was that they were introducing vasopressin in the protocol for management, but then subsequently vasopressin was removed, atropine was removed. Like atropine was earlier used thinking that it will help in stabilizing the heart rate of the patient, but clinical studies showed that it causes no survival benefit. So when you compare 2010 and 2015, then atropine and vasopressin have gone out, and this is the standard protocol that I've discussed before you. Now they decide to add an additional drug or remove an additional drug is the only thing that you will have to remember in the October 2020 update. That is what is mentioned on the ACLS website of America Heart Association. They said that they update the data every 5 years. So it's not that there is a 2016 2017 update. The data is updated every 5 years. They basically collect all the information of such patients from intensive care unit and then do a analysis, meta-analysis, to find that every step that we are doing, is it causing any survival benefit for the patient or not, and based on that the guidelines are formulated. So thank you so much for your patience and hearing me out, and this will definitely help you in your subsequent career as well. Thanks.